time now for a panel discussion. I'd like to call on Karen May, the Associate Director of the Australian Centre for Excellence for PTSD, to the stage and to introduce our panel.
Now, I'd just like to introduce a couple of our panellists that you haven't been introduced to yet today. Today we do have Michael Morgan, who is our Chief of our Metropolitan Fire Service here in South Australia. I'm very excited to have you here, Michael. Michael joined the MFS in February 1986 and progressed through the ranks to his current role as Chief Officer. He's worked a lot with work health and safety programs with the fire service, and Michael has also joined the Board of Governors of the Road Home to support further research in this area. We've also got Matt Newlands here today, down the end there. Matt has worked as a police officer with the South Australian Police from 2006 until 2016. Matt was diagnosed with PTSD and depression in 2015 as a result of accumulative trauma, which ultimately resulted in his life spiralling out of control. Matt now uses his lived experience to assist others, and we'll talk more about that in a sec. And Dr. John Lane, who will be presenting later today. But Dr. John Lane is a great colleague, worked closely in our research centre. He's still an active reservist, enlisted as a soldier in the Army in 1989. After working as a soldier for 10 years, in 2013, he was deployed to the Middle East area operations, working with the US mental health team at the NATO medical unit in Kandahar. Kandahar's in Afghanistan. As the first ADF psychiatrist to be directly embedded with the US forces. He is now also completing a PhD in a peer-led group treatment for serving personnel through the Centre for Traumatic Stress at the University of Adelaide, and in partnership with the Road Home and Mates for Mates, another ex-service organisation that's here with us today. So thanks, John. You know Miranda from yesterday. If those of you who weren't here yesterday, Dr. Miranda van Hooff is one of our leading Australian researchers with longitudinal empirical research into both veterans, but also led the Metropolitan Fire Service study. And Stacey, we met this morning. So thank you guys for being with us. I'm just going to ask a quick question, but I really do want to throw out to the floor for any questions that the audience do have. So, Michael, as Chief of the Metropolitan Fire Service in South Australia and a member of the National Emergency Service Forums in our country, your organisation has undertaken an extensive study of mental health. I believe it's the first major study of an emergency service in Australia, putting your organisation under the microscope. What was it like for you, and what are some of your takeaways?
Thank you, Karen. I must admit that when it was first suggested through Adelaide Uni and Sandy McFarland, for those that hear, they had done the research into the Defence Force, so it was aligned to that. There was some fear associated with going. We had an understanding where we thought the organisation was, but certainly the study would. We were fearful of where that would put us as a workforce. And the great part about doing the study is that it's given us the burning platform, I guess, to now move forward and look at ways of improving conditions and training and awareness for our staff. Our roles have changed. When I joined, we fought fires, we did a little bit of rescue, and we see road crash rescue and other rescues now going up and fires are going down. So our exposure is increasing. And so for us it was about, certainly about how do we better prepare our firefighters coming in, how do we look after them whilst they're in service, and then certainly that transition to retirement, and then their health and wellbeing beyond. But the study was really good for us, and we went to government in our enterprise agreement, enterprise bargaining process previously, and sought additional staff to support that.
I know you've been a big advocate within your own workforce and over your career, and I know you often share the story of some of your early experiences and how that impacted you.
Sure. When I first joined, I remember going to my first double fatality, husband and wife, both nurses coming home from night shift. We ended up under a truck. I'd only been in the job about 4 years, and going back to the station and feeling how I felt, but looking at the rest of the crews and thinking, there must be something wrong with me, because they seem to be quite comfortable. They were drinking coffee and eating morning tea and being quite jovial about it, and I felt sick to the core. So I started to challenge myself, thinking, am I in the right job? Have I got the right makeup? But I soon worked out that that was the way that those firefighters had sort of been processing and dealing with issues previously. I became a peer of our peer support team after one of our colleagues suicided. So I got a phone call from the deputy chief at the time and said, I'm picking up in 10 minutes, you need to come with me and tell the partner of the firefighter that he suicided. So I became a peer through that, and then became the employee support coordinator, then managed the program, and it's sort of been a passion of mine and stayed with me through to my current role.
We're very lucky to have you.
Thank you.
Miranda, so you worked on the on this study on the MFS, and you're now also a supervisor on some other projects, and with John Lane's PhD. What were some of the key outcomes or learnings for you in this study as an experienced researcher, a veteran, and other cohorts?
Probably the most remarkable finding really from this study is the low rates of mental disorder in this population. I'm sure Michael was very pleased to hear that when they came through. As I mentioned yesterday in my presentation, the rates we're seeing for diagnosable disorder in the MFS are pretty equivalent to the Australian population rates. And even looking at the rates there today in Canada, for PTSD, for instance, they're looking at about 13.7% in Canada. We have 5%, and that's 12-month, whereas theirs is current. So the rates are extremely low, and which is actually really remarkable when you think about the level of a trauma, potentially traumatic events that the MFS personnel are exposed to, sometimes on a daily basis. So there's certainly something that these guys are doing right. The other amazing thing about this whole research program was when the study was released, when the findings came through, we did a big media release, and the way the MFS embraced the findings that we had was just amazing. They owned it. There was some problems. It wasn't that everything was smooth sailing. There were some issues there, particularly when we looked at functioning, for instance, work functioning was really great, but there was some issues there with family and social functioning, and the mental health symptoms impacting in that space, which also supports the family model here. So it certainly wasn't all smooth sailing, but the MFS embraced that. And in fact, one of the findings we had was that the events that were causing the most psychological distress were call-outs to a mental health incident. And clearly that's because they're not feeling as though they have the skills to know how to deal with that particular situation. And almost immediately after these results came out, Michael put the entire MFS through mental health first aid. So, and I think this is why, they're doing so well, because they're reactive and, and adaptive, and they take what they're told on board and they do something about it. So it's been a really rewarding experience working with them.
Thanks, Miranda. Now, Matt, we come to you. You've had your own lived experience with post-traumatic stress as a police officer, and you've decided to work to assist others as a peer counsellor. What's been important to you during this process from injury to recovery?
Thanks, Karen. I think the critical turning point for me was really around connection, acceptance, and then conversation. And I think it's quite important that it's almost in that order as well. So for me, I was diagnosed in January of 2015. I think the first time I explained my diagnosis to anybody in SAPOL was in August of that year. So there was a lot of self-stigma and also a lot of organisational stigma and I think is still in existence today. I think that will be broken down through that process of connection, particularly with peers and colleagues. That was difficult for me because in my diagnosis ended up resulting in my termination from SAPOL. In rather dramatic circumstances, which we don't have time to go into today. But for me, it really is around connection, feeling accepted, and then having a conversation, a really honest and authentic conversation around what that diagnosis means. And I think that's what the STARE program I've found really offers, those three critical points.
So, John, just to follow on then, as Matt's referred to you and the STARE program, so you've developed a therapeutic program, a group program, with content which is specifically designed for first responders as well as veterans. Also a practice manual that can be delivered for first responders, by first responders and others in agencies that work with them, both from a prevention perspective but also wellbeing maintenance, and once people do have a psychological injury, giving them strategies on how to manage it. So hearing some of the other speakers today and some of the models from Canada, Stacey and so on, what would be your vision for further development for the first responder organisations and any of the policymakers in the room?
Thanks, Karen. That's not an easy question to answer, but but you know, the range of presentations we've had today has been amazing, and you know, listening to Stacey and what you've got organised, I think the next step is to actually empower peers to have some sort of an intervention that they can deliver, and that's where the STARE program and the new GEARS program is going to step up, I think, because we need that level of cultural competence, full stop, within the organisation. And for organisations to be able to manage their personnel properly, there has to be interventions that welfare officers or support officers can actually have at the grassroots level, rather than external supports or other agencies and so on and so on. I think we do tend to have an issue with siloing care and care models, and hence going back to that sort of grassroots level and having functional skills-based interventions at the coalface are really important, and it's not something that we're doing yet. But I think, with luck and a bit of effort, that might come up further down the track.
Thanks, John. And Stacey, I think we can all agree that Stacey's organisation have such a comprehensive support service available for police in your area. But are there areas that you would like to see more development?
Yeah, for sure. I mean, I think just adding on to Matt's comment around connection, I think because a lot of our members come forward and ask for help, it's actually not about psych services, it's about peer support. And so we have a very comprehensive peer support program in Calgary, which I think really, peer support is the bridge to psych services. And so I think where there is some limited research is around how peer support programs are evaluated. And not every policing agency or fire department or paramedic department has peer support in Canada. So I think, it would be good to see more data coming out around the effectiveness of peer support programs and what makes them effective.
Thank you, and I think for those who are also interested in that topic, do catch John's talk later, because a lot of our agencies do have peer support, but one of the things that organisations have been grappling with is how do you lead a peer support organisation, how do you create structure around that to protect the peers, but also those that they're supporting, and that's what John's attempting to do with his project. Now I'll just throw it out to some of the questions from the audience. So one of the questions, which is a good one, is with so much focus on intervention, early intervention, is there research or programs looking at more mental health literacy training in early careers of ADF and first responders? Would anyone like to respond to that?
I can, but I don't actually believe there is any at the moment. I certainly know that there's not a lot in the ADF, and in the South Australian first responder space I don't think there is either. I don't know from the international context whether there's much in that space, but in Australia there's not.
I'm wondering, and I don't know about Australia, but do you have the Road to Mental Readiness? No. So the Road to Mental Readiness is oh, we do? Yeah, there's nods. Yeah, I mean, I think that's what I would say is, especially in Canada and the States, the RTOMA program that is derived from the Department of National Defence is something that is heavily embedded in a lot of first responder agencies. Mm-hmm. And really that's to support leaders in opening those conversations about mental health with their employees.
Another good question here from the audience. Any thoughts about retirement issues? So post-traumatic stress issues can worsen, as we heard, in transition from ADF, but also what about first responders with advancing age and loss of the camaraderie and identity can be a problem too.
Thank you. We had a conversation about this last night. Certainly, doing the study identified a number of issues, but one is that on average, our firefighters in South Australia do 30 plus years of service. So it's ingrained in your life, and I use myself as an example. You know, I'm in my 34th year. I've hopefully got a few more left. By the time I finish, you know, suddenly I walk out on Friday as Michael Morgan, the firefighter, and then what am I on Monday? My wife always jokes about I get ready quickly because all I have to do is put on a fresh shirt, and it's the same shirt every day, and pants. But so it's about so what we're looking at is this really the work that we want to try and do as a result of the study and other studies that are happening is about that recruitment, you transition through your career, and then how do you retire well, so physically well and mentally well. So, and again, it gets back to that information and training that we provide our staff throughout their careers. I think we're doing some good work now. New recruits are certainly made aware of what they're going into. We have an evening with their family members, partners, spouses. But what we would like to see is this: financially, we all plan to retire, and so you'll seek financial advice years out. But for the emotional and the psychological transition to retirement, I don't think we do very well sometimes. And I've witnessed that sometimes it's a very quick decision within weeks and someone's gone. Others will stay for years and contemplate going. So it's a challenge that we're facing, but certainly something we'd like to continue to work in. And we're looking at what the military do around their transition to retirement. Although sometimes it's different, it's transition to another employment. So yeah, there's lots of work to be done.
Yeah. On top of retirement issues, we've also got the access for the families, and I know that some of the organisations, from police to fire to ambulance and so on, are allowing family members to access the EAP programs, but it's often not well known about, and sometimes it's quite ad hoc or discretionary as well. So we just have a question or more of a comment around that, about trying to promote or perhaps make a more streamlined access program for families around that as well. You wanted to make a comment?
Yeah, just following up on Michael's comment earlier, and in relation to that question about retirement, I think that's why we need to actually adopt a life cycle approach to mental and physical health in the military and in all the emergency services. Because basically life is just a series of transitions. So you transition into the force, you transition out of the force, and then you may transition to another job, and then out of that job, and then you transition into retirement. And all of those key points in a person's life are likely to could trigger a spiral of negative effects. So I think we need to stop thinking about mental health or physical health as discrete episodes in one's life, and think about how this is going to go up and down over the life cycle, and think of it a bit more holistically.
Matt, did you want to make a comment?
Yeah, I was going to say, I think it's also really important to understand that a lot of those same transitions occur for those that are either, I guess, sacked through their roles, or go through a particular set of circumstances where they're unable to return to their role too. So for many that I talk to, there's a fear of what their identity looks like beyond their diagnosis as well. So they may still be in the job, but they're not fulfilling the role that they were before. So I think there still needs to be that transition focus. You know, even for someone like myself, they took 12 months to put me through the academy, and I think in about 45 minutes they took my uniforms and my badge, and that was it, and I haven't heard from them since.
That's a common theme. Now, I think we're out of time. Graham, are we? Yes. So I'm sure there's lots more discussion to be had around this, and we'll have the other themes throughout the day around some different programs and models, and please do catch up during the breaks to continue the conversation. Thank you.